Good morning. It's a beautiful spring day in the western mountains of Maine. This is the time of year that we start seeing a lot of running injuries, especially lower extremity. And I thought I would present a case study that illustrates a good usage of the 6 out of 10 test. More often in our protocols, the 6 out of 10 test is kind of a smaller piece of the bigger picture, but in this case, it proved to be the critical piece of diagnostic information that cracked open the case. I'm calling this one a cold case because, as you'll see, it wasn't really going anywhere until we figured out exactly what was going on. So we'll get right to it. This was a 51-year-old male runner. And 10 years prior, during a 10K race, he developed a stabbing right outside calf pain. And since then, hasn't been able to run more than a day or two a week at a slow pace. Anything beyond that, anything further or faster, and his calf would seize up again. You'd have to take a whole month of recovery off from running before you could try it again. And it was just kind of stuck in this cycle for the past 10 years. No prior history of foot or ankle injury. He was a former basketball player, so it's possible there's some ankle sprains that he forgot about, but nothing that stood out in his mind. He saw sports medicine. X-rays were normal. They did an MRI. Mild, quote-unquote, edema in the lateral gastroc soleus, and also prominent veins, which prompted a referral to a vascular specialist. They did a treadmill Doppler evaluation to evaluate blood flow, which was completely normal. It turns out the vascular surgeon was a triathlete and a patient of mine, and he suggested he let me take a look at it. So I saw him, and on the exam, as expected, lateral gastroc soleus, extremely tight and tender. The peroneals on the affected side were inhibited. This is interesting. In the literature, when they measure peroneal inhibition in response to ankle dysfunction, it's kind of all over the map. Sometimes it's facilitated, sometimes it's inhibited, sometimes there's no change. I have yet to find a pattern with the peroneals, but in this case, they appeared weak to the point of inhibition. All other lower extremity muscle testing was okay. He had a pretty strong core. This is also significant frequently in the cases of a recurring soleus, especially strain. We find maybe some sciatic nerve involvement coming from the piriformis, the pelvis, but that seemed pretty intact in his case. The ankle on the affected side, ankle joint complex joints were fairly restricted, supporting maybe the history of a past ankle sprain that he'd forgotten about. I didn't do a running gait evaluation. If I recall, he was just coming off of one of his episodes and didn't feel like he could run normally. But in a walking gait evaluation, it appeared pretty normal. So my initial working diagnosis was that the lateral gastroc and soleus were compensating for the peroneal inhibition, a case of synergistic dominance. I didn't have full confidence in this diagnosis. Again, this case seemed a little atypical, but you have to start somewhere, so this is where we started. So treatment-wise, because I was hypothesizing that the issue was stemming from the ankle, focused on ankle joint manipulation and soft tissue work to get things moving better. Peroneal strengthening. Funny side story, this gentleman was an anatomy professor. He's actually the one that told me we're no longer calling them peroneals. They're now the fibularis longus and brevis, but I apologize, I'm kind of old school. I'm still stuck on calling them peroneals. And his lateral gastroc, soft tissue work, obviously. And things seemed to release pretty nicely. Being an anatomy professor, I thought he would think that was cool, but like a typical runner, he was just more interested to know if he could run again. And within 4 treatments, he could. Things were improving. Several test runs went pretty good. Unfortunately, on the last test run, things completely relapsed and symptoms fully returned. So back to square one. So we did a reevaluation, and the biggest finding was that now that the gastroc soleus were looser, I could appreciate that underneath that, the flexor hallucis longus was actually still quite tight. Anatomically, it's kind of a sneaky one because it attaches to a medial joint, but it starts pretty far lateral. And importantly, FHL was not reducing with a 6 out of 10 test. This is kind of a rule of thumb I have, is you always want to make sure you can put your hand on the structure that hurts. If somebody comes in telling you they have IT band, just take that extra minute and make sure it is indeed the IT band and not the lateral quad or the lateral meniscus. So in this case, I originally couldn't really appreciate FHL because the superficial structures were so tight, but now that they were looser, I could tell. And based on that, I kind of queried him more closely about any injuries to the big toe, and now he did happen to remember that yes, 8 years prior, I broke my big toe. Now this was 2 years after his symptoms had already started, so it doesn't explain everything, but it seemed like a piece of the puzzle. His ankle joint range of motion was improved now. However, notably the first ray, cuneiform, metatarsal, MTP joints were still quite restricted. So for the next few treatments, we focused on that first ray, doing some manipulation to the metatarsal, cuneiform, first MTP. Did some soft tissue work in that area. I use the same adjustment, by the way, as I do for the rest of the ankle joint complex. He was a pretty big guy, over 6 feet with a big foot, and it was difficult to, I didn't feel like I had the arm or hand strength to release it that way, but this way, using the glutes and hamstring, and you can generate the power that you need to get things released. And importantly, after a few treatments, FHL was now reducing to the 6 out of 10 test. It was no longer in lockdown. So it was willing to let go, and based on that, I now felt like I could get some response with a lengthening technique like ART. So the results from this second round of treatment was that it worked. He was now able to resume a regular running schedule, 3-4 days a week at a pretty good clip, and with no issues. He was fixed. This was back in 2014, and I think I saw him maybe once since then, just for a tune-up. I think more than anything, he just wanted some reassurance that he was okay to continue running, and haven't seen him since. So if you look at the take-homes from this case, the first one is that in this case, the diagnosis was really the tricky part. Oftentimes with repetitive use type injuries that we see, your Achilles or plantar fasciitis, they're not difficult to diagnose. They're difficult to treat, but it's not too hard to palpate the PF and say, yep, this is plantar fasciitis. History and anatomy were the keys to this case. So knowing that I was palpating FHL and not just the gastrocsoleus, not just blindly following the MRI findings, but doing your own due diligence and realizing what structure you're on. And that's what kind of clued me in to ask him about the big toe. And he remembered that injury. By the way, I love it when that happens. It makes you look smart when you cue somebody, hey, have you ever hurt these ribs before? Well, yes, I have. How did you know? The fact that the FHL was in lockdown was a key. It was failing the 6 out of 10 test, and that means that no soft tissue technique is going to work in this case. Trigger point work, ART, dry needling, nothing's going to get that to let go until you address the lockdown. In this case, it was the first ray. Another point I'd like to make is that exacerbative factors were not applicable in this case. So running shoes, running form, the fact that he wasn't a big stretcher, it can be a trap sometimes to blame too much on these kind of exacerbative factors and not really get to the root of the problem. I'll finish by saying that from a practice management point of view, when you learn how to successfully treat athletic extremity injuries, you really open up a whole nother avenue of referrals. These people tend to be pretty motivated, and if you develop the reputation as the guy or the gal who can fix these things, they will come and they'll keep coming back and they'll send their friends. As always, thanks for listening. So if you haven't already, you might want to check out the other video we put up called Muscle Lockdown and the 6 out of 10 test. That'll more thoroughly explain the test and the concept of muscle lockdown.